Good morning, good afternoon, everyone. Welcome to the APASL webinar. It's going to be every Saturday at 4 Beijing time. See you every Saturday here for the webinar to update you the hepatology and forum and also the update the COVID-19 situation. Moreover, this month, we're going to have World Hepatitis Day on July 28th of every year. So APASL, together with WTO, World Congress of Gastroenterology, will organize the webinar to this special event during the July 28th. So please join us at the webinar. This is going to be speakers from all around the world, from the Western and Eastern, in order to touch upon the management of chronic viral hepatitis, how we can overcome the problem of chronic viral hepatitis. Without further ado, I will pass my task to the moderators of today. Professor Dr. Mercy will introduce the first speaker for today's webinar. Professor Dr. Mercy, please.
Hello, in Turkey, good morning, and also the East people, good afternoon. Today, there are two speakers in our webinar. The first speaker, Professor Tarik Asselah. I would like to introduce him. Tarik Asselah is a full professor of medicine and hepatology at Hospital Bouillon in France, at the University Paris Diderot in France. Tarik Asselah is the head of the viral hepatitis at ANSERM Center of the Researchers. He also holds as a PhD in virology. His fields of research include chronic liver diseases, translational medicine, and treatment of HBV and HCV infections with new direct-acting antivirals, for which he was being involved as a coordinator, principal investigator in several clinical trials. He coordinated major international clinical trials on HCV genotype 4 infection. He has published more than 250 articles in the field of chronic liver disease in major journals. He has been selected as a rising star in gastroenterology in 2009 by the United European Gastroenterology in appreciation of his outstanding scientific work. He received awards for his genomic studies on HCV in 2005 from the French Association for the Liver Disease, and for his leaders in hepatology in 2019 from the Czech Hepatology Society. Yes, as you can see here, Tarik is very scientific person, and he's going to speak right now. Yes, Professor Tarik Asselah.
Thank you. Hello from Paris. Thank you, Professor Dr. Mercy, for this very kind introduction. Professor Wei, I'm very pleased to speak at this APASL web seminar. It's a pleasure to be with all of you. So I will start now my presentation. Dear colleagues, ladies and gentlemen, I'm pleased to present today drug development for the COVID-19 disease. These are my disclosures. I'm a full professor of medicine at University of Paris in France. To start with a quotation, there are no incurable disease, only the lack of will. There are no worthless drugs, only the lack of knowledge. Ibn Sina Avicenne. I think it's a very positive message for drug development. During this lecture, I will follow this agenda with a short introduction about the coronavirus disease, then epidemiology, the last available data, then virology, what is important to know to understand drug development, then drug development and take-home message. So the goal of this lecture is to understand together drug development for this important pandemic. Severe acute respiratory virus SARS cause coronavirus disease. SARS is a new coronavirus. It's a family of enveloped positive sense single-strand RNA viruses. It has been identified in patients with pneumonia in Wuhan, China, late last year. It started by infected animals and now spreading between humans. And the receptor has been identified. It's the angiotensin converting enzyme 2 receptors with high affinity for the spike protein of the virus. How do we get contaminated? It probably spread as flu through droplets in the air. Individuals get infected when these droplets enter the nose, eyes, or mouth. So you should not touch your face, because if you touch contaminated objects, droplets can go into your hands. Individuals have also been infected after contact with infected person, even with no symptoms. So asymptomatic carriers can also transmit the disease. What about the symptoms? SARS-CoV-2 tends to cause mild respiratory infections. The fatality rate is usually around 1 to 3% for infected persons. It depends on the population. And acute respiratory distress syndrome, ARDS, due to the virus, to a cytokine storms syndrome occurs in patients with severe disease. Risk factors for mortality include obesity, advanced age, diabetes, hypertension, and other comorbidities. What about COVID and the liver? Biliary cells, cholangiocytes, have high expressions of the angiotensin converting enzyme 2, the receptors for the virus. Therefore, they can be infected. Liver injury has been observed in patients with COVID-19. And in a report from China with liver injury, there were more patients with NAFLD, non-alcoholic fatty liver disease, and with high BMI with obesity. And patients with non-alcoholic fatty liver disease had higher risk of progression to severe COVID and longer viral shedding time. And an excellent synthesis of liver associations, recommendations for hepatology and liver transplantation has been recently published, and we encourage to read it. How to prevent the infection? You can wash your hands frequently with soap of water, it's preferred. If not available, you can use alcohol-based. You can wear mask in closed space, and it's very important to adapt early and strong social distancing efforts to stop virus transmission. Of course, case isolation and contact tracing has proven their efficacy to reduce the epidemic. Testing and tracing programs will be essential. Later, testing, tracing, and treating will become mandatory once effective and safe therapies will be developed. Now, let's move to epidemiology. What are the last data? You can see, according to the World Health Organization, WHO, that around 30 million of patients have been confirmed with COVID. So it's maybe underestimated because we don't have the availability of the test, the diagnostic test worldwide. And there's already 500,000 of patients died from this disease. You can see that it's increasing worldwide in Africa, America, Europe, Asia, and there's also more and more patients worldwide. You see the situation report from the WHO released on July 15th that there's huge concern in North America, South America, but also in India and also in South Africa. You have in brown, when you have many cases reports the last 7 days, and it's a concern in all the world, especially in Africa, when the healthcare system is not very well developed, advanced. You see here represented in this report the number of new cases diagnosed confirmed. It's an underestimation because it's diagnosed confirmed, but you can see that the huge problem in the world. So we have seen the COVID-19, how it is transmitted. What about the epidemiology with all the world attacked? And now what about the virology? How to understand better the virus to fight against this virus. You see that it's a genome, RNA genome, with a capsid and with envelope and spike proteins important for attach to the receptor in infected cells. The genome codes for enzymes, protease, polymerase, which are very important because we can use them as antiviral targets. So this is the structure of the virus, RNA single-strand genome with a capsid and with an envelope and with many enzymes important for the virus replication cycle. The sequence of the virus by Chinese groups which share this scientific information with the world has allows rapid development of diagnostic tools. And as diagnostic tools, we have either molecular tests with PCR, so we have the diagnosis for ongoing disease, detection of viral genome by real-time PCR. And we have on the other side, serological tests, immunoassays, that allow the detections of antibodies to see which patients have been contaminated in the past by the disease. We have to improve sensibility and specificity for these serological markers. Also in development, there's rapid diagnostic tests, RDT, that are very important also and are in progress. So it's very important to develop these diagnostic tools. So what about the viral replication cycle? You see the virus N3 with the receptor identified, ACE, in step 1. Then in step 2, you have encoding, proteolysis, amplification of genome RNA synthesis. In step 3, you have production of subgenomic mRNA. In step 4, you have assembly and release, and then infection of other cells. So the viral replication cycle is very important because each step is a candidate for drug development. We can block each step of the virus, so a better knowledge is mandatory. You see the targets for drug development according to mode of actions. You have N3 inhibitors to block the N3, and you have examples as arbidol, chloroquine, camostat, convalescent plasma immunoglobulins. You have protease inhibitors like lopinavir, ritonavir, developed for the HIV disease. You have other drugs. You have inhibition of the viral polymerase, ribavirin, remdesivir, and this viral polymerase has similarities with other viral polymerase like Hep C, and it's why some drugs have been tested for different diseases. You have inhibition of translation and release with interferon beta. Interferon has been a treatment and is used for hepatitis B. It has been used for hepatitis C. And you can have also vaccine development and inhibition of the inflammation, the cytokine storm, with tocilizumab, sarilumab, ruxolitinib, and baricitinib for some examples if you want to have an anti-inflammatory effect. We do understand that early in the disease, in the early steps, we need to block the viral replication with antivirals. In the late stage, with more inflammation, we can use anti-inflammatory. Of course, you can combine two treatments with two different modes of action to increase the chance to fight against the virus. So we have seen the introduction, the COVID disease, how it was identified by Chinese group with a very rapid sequencing of the virus, sharing this information worldwide. So we thank all the scientists worldwide to share information. We know the epidemiology, it's a pandemic with all the world attacked by this pandemic infection. The virology, it's very important to understand better the coronavirus, the viral replication cycle, to develop new drugs and to understand drug in development. So what about drug in development, the key messages? Drug repurposing is a strategy to identify new use of for already approved drug. So we can go faster because we know this drug is approved. We don't need tolerability, toxicity studies, and we can go rapidly to phase 3. And this strategy has been developed for the COVID-19 disease. Antivirals may be used in the early phase to decrease viral replication, and anti-inflammatory drugs in the late phase to reduce the inflammation. We can combine antivirals and anti-inflammatory drugs together. To date, with the exception of 5 days intravenous remdesivir or dexamethasone, with a modest effect but significance on severe COVID-19, no strong clinical drug has shown efficacy or safety today. So we need to pursue, to continue drug development. A better knowledge of the virus and the immune response will be mandatory to develop new drugs. A vaccine to prevent infection would be crucial to obtain. However, it may not be available before 2020, if at all. But big investment has been done to help the vaccine development worldwide. This is some example of drugs evaluated in clinical treatment for COVID-19. This is antivirals. So you can have the drug, the company, the structure of the molecule, the current use or initial target, the mode of action, the mode of administration, and the clinical number, identification number, registration numbers. As example, you have remdesivir, you have chloroquine, you have lopinavir, you have favipiravir, imipevinor, carmostat, and ribavirin. And you can see that these drugs have been tested in other viral infections, Ebola, malaria, HIV, influenza, Hep C, because they share some same enzymes like polymerase or protease. So it's drugs that are being evaluated. It's not exhaustive, it's just a selection. For anti-inflammatory drugs, you have interferon alpha 2B, you have tocilizumab, sarilumab, and baricitinib. And you can see also the drug, the company, the structure, the current use, or initial target, the mode of action, mode of administration, and the registration number. And you can see that these anti-inflammatory drugs are used for rheumatoid arthritis, for inflammatory disease. So I think it's very important to see if they're working in this disease, alone or in combination. Again, it's a selection of treatment. I will present you some trials. I made a selection because we know that there are more hundreds and hundreds of ongoing studies. This is the WHO Master Protocol Solidarity trial. It's a large phase 2-3 adaptive, multi-center, randomized, open-label trial of the safety and efficacy of treatment for COVID-19. So you have a standard of care, then you have remdesivir, you have lopinavir, ritonavir, lopinavir plus interferon beta, and you have also hydroxychloroquine. We know already that some of these treatments have no effect or mild effects, or maybe they are tested too late when patients are hospitalized. We know that lopinavir, ritonavir has not shown strong effect, and also chloroquine. You have the key inclusion criteria. Patients are hospitalized, adults, with the confirmation by PCR of the SARS infections. And you have also exclusion criteria. And you have the endpoint, which improvement in clinics for these studies. You have the clinical trials now on remdesivir. So you have many studies with the study ID identification, the study design, the location, the sponsor, the study size, and the primary endpoint. And already some of these studies have been published in top journals when you have partial data or early data. And we know that remdesivir did not achieve his first endpoint, the goal of reducing mortality, but there's a reduction of number of days of hospitalization, so a positive message for this treatment. So the first take-home message, group from China has rapidly identified and sequenced the SARS-CoV-2, a new virus with a high sequence identity with bad-derived SARS-like CoV. So the sequencing of the virus allowed the development of diagnostic tools, PCR. And additionally, we have serological tests for the disease for patients who have been infected. Testing and tracing programs will be essential. Later testing, tracing, and treating T3 programs will become mandatory. Early and strong distancing, social distancing are needed. In addition, the use of masks, swabs, disinfectant are essential to reduce or eliminate virus spread. Case isolation and contact tracing has proven also efficacy to reduce the epidemic. So it's very important. So the first message, science has gone very fast and scientists share all this data. We know the sequencing of the virus. We know to make some diagnostic tests, thanks to some research from groups in China who share all this data with all the sciences worldwide. Science and medicine are universal. Second message, drug repurposing has been used to rapidly identify treatment for this infection, and many treatments move quickly to phase 3. To that, except for intravenous remdesivir or dexamethasone with mild effect, but significant on severe COVID, reducing the days of hospitalization, no drugs has proven efficacy and safety. Of course, a better knowledge of the virus, its enzymes, and immune response will be mandatory to develop direct-acting antivirals, immune modulators, and effective vaccines. And maybe we will need to combine different treatment with different mode of actions. A vaccine to prevent infection would be crucial to obtain, but there's a long way to go. Dear colleagues, ladies and gentlemen, I'm very pleased to give this lecture for the APASL. And finally, how to achieve SARS-CoV through elimination altogether. We have first to make prevention with washing hands, distanciation, face mask, case isolation. We have also with prevention to improve test diagnosing with PCR together with serology, point of care, case tracing. And finally, we have to develop drug development with all efforts together to treat with drug repurposing, new drugs with new mode of action, and develop a vaccine. And thank you for your attention. I will be pleased to take questions.
Thank you very much, Professor Asselah. It was really excellent speech. I think it will be better to discuss the first talk at the end of the second talk, I think.
Perfect.
It's okay for you? Okay, because this is almost the same subject, you know. Okay, then now my co-moderator, Professor Wei, please introduce the second speaker.
And good afternoon, and ladies and gentlemen and colleagues. It's my honor to introduce the second speaker in this afternoon, APASL Hepatology. And second speaker is Professor Wen-Juei Jeng. He's the Associate Professor of Medicine and Chang'an University and Chang'an Memory Hospital, Ningkou branch. And actually, I think, and we are and the colleague. Currently, I am working in Beijing Chang'an Hospital. So, and the Professor Zhang, and also did a very good contribution, and has a few of the honors and awards. And he also have many and the academic and the position, and also published very important papers on hepatitis B and hepatitis C. And this afternoon, and the C will bring us for the topic on cessation of the nucleotide and the treatment in chronic hepatitis B. So please welcome Professor Zhang.
Thanks, Chairman, and good afternoon, ladies and gentlemen. Greetings from Taipei. I hope everyone is well at your country. under the epidemic of COVID-19. And I hope the following lecture, you will enjoy it, and welcome for discussion afterwards. Thank you. Good afternoon, Chairman, ladies and gentlemen. I'm Dr. Jeng from Chang'an Memorial Hospital, Taiwan. I'm very honored to be invited by the APASL Association to give the webinar entitled Cessation of NUCs in Chronic Hepatitis B Patients. This is the outline of my today's talk. First of all, let's discuss about how antiviral therapy improves prognosis in chronic hepatitis B patients. This is the natural history of HBV infection. In immunoclearance phase and reactivation phase, patients may have encountered fluctuation of the ALT level. If the inflammation persists for too long, accompanied with the high viral load, the patients are at risk of hepatic decompensation and development of cirrhosis and hepatocellular carcinoma. And this is the goal of therapy for the chronic hepatitis B patients. In short term, we hope to help the patients to normalize their ALT level by suppression of the HBV viral load, which in long term will reduce the liver disease progression to hepatocellular carcinoma and cirrhosis and prevent the liver-related death. The ultimate goal for the HBV therapy is to achieve the HBs antigen seroclearance, which we also call the functional cure. From the large Taiwan National Health Insurance data, it shows that the antiviral therapy can reduce the HCC incidence by 5 years. On the right-hand side, this is the famous C-TEAM study composed of the multi-center cirrhotic patients. By long-term use of entecavir, the cumulative incidence of HCC and liver-related mortality reduced greatly. For a recent Hong Kong large cohort composed of the 20,000 patients treated with entecavir or tenofovir, we can see the patients have the HCC risk reduced when they have the complete virus suppression compared to those without complete virus suppression. However, the lowest risk goes to the patients who had HBs antigen seroclearance, which has the only 0.6% of the 8 years cumulative incidence of the HCC. And this is why the functional cure is the endpoint of the antiviral therapy. Let's move to talk about how the concept of the finite therapy emerged. This is the HBV life cycle. The nucleoside or nucleotide analog acts on the reverse transcriptase inhibition, and this will result in the lower of the HBV viral load. However, the nucleoside or nucleotide analog cannot eliminate the existence of the cccDNA, which serves as a stable template for the HBV existence. The use of the serosurface antigen, which can stand for a surrogate marker of the cccDNA and the infected hepatocyte. These two studies come from Greece. Each 100 patients treated with entecavir and tenofovir for 4 years. It is obvious that the HBs antigen level decreased very, very slow during the 4 years of the antiviral therapy. Only less than 10% of the patients can achieve greater than 0.5 log reduction in 1 year. For a large cohort composed of the 1,781 patients, the annual incidence of HBs antigen loss during antiviral therapy is only about 0.15%. This phenomenon has also been validated across different studies with different HBV genotype and different ethnicity. With an average decline of 0.08 log10 reduction per year, it has assumed that the patients may take more than 5 decades of the nucleoside or nucleotide analog to achieve the functional cure. Thus, this is the summary of what the patients will encounter when the lifelong therapy given. Cost of the medication is one of the major problems in many Asian countries where HBV infection is endemic. When the patients are not treated with the high-potent NUC such as entecavir, tenofovir, or TAF, viral resistance will emerge along with the longer treatment duration. In the recent studies, patients are willing to take the lifelong therapy only 44%, even when they are being reimbursed. During 5 years of the antiviral therapy, 1/3 of the patients have the non-adherence issue, and this problem is aggravated by longer treatment duration. 7% of the patients lost to follow-up during 5 years of NUC therapy, and this will result in their risk of hepatic decompensation and severe reactivation when these patients are not monitored unscheduled. And thus, the concept of the finite therapy emerged to eliminate the problems we are talking about. APASL Association is the first guideline that proposed finite therapy can be considered in the inactive patients when the patients are treated with the nucleoside-nucleotide analog long enough to achieve undetectable HBV DNA on 3 occasions with 6 months apart, similar to the 1-year consolidation concept for the E-positive patients who had already achieved E-antigen loss. In 2012, additional suggestion that nucleoside-nucleotide analog treatment duration longer than 2 years, besides the consolidation duration longer than 1 year. This is what we call the APASL stopping rule nowadays. After NUC discontinuation, close monitoring of the patient is mandatory to keep the patient safe. The guidelines suggest that ALT should be monitored monthly in the first 3 months. Then ALT and HBV DNA monitored every 3 months in the first year. Thereafter, ALT and HBV DNA every 3 to 6 months. Once the patient has increased ALT level, serum ALT, bilirubin, INR should be monitored weekly to biweekly until the retreatment decision made or the ALT level return to normal. This is the current guidelines for stopping NUC. There is a consensus for the E-positive patients that NUC discontinuation can be considered in the non-serotic patients who had achieved stable E-antigen seroconversion and undetectable HBV viral load longer than 12 months. However, there is no such consensus for the inactive patients. Apart from the APASL guidelines, which propose finite therapy be possible, the EASL and AASLD propose that NUC therapy should be given until HBs antigen loss, which stands for lifelong therapy for the inactive patients. However, in recent years, they have changed the guideline to stopping NUC may be possible in the selective non-serotic patients after 2 to 3 years consolidation duration. And now we move on to the short-term outcomes of finite therapy. This is the recent systemic review composed of 1,700 patients. Biological relapse occurred more than half in E-positive and inactive patients. 42% of the inactive patients may encounter clinical relapse, while it is lower in E-positive patients. That of therapy relapse is not an uncommon phenomenon. From the left side figure, it demonstrated that the clinical relapse pattern differs by different NUC. Patients stopped entecavir has later clinical relapse. More than 70% of the clinical relapse occurred after 6 months. However, patients treated with non-entecavir and after stop, the patients will have the clinical relapse earlier, and 86% of the clinical relapse occur within 6 months. This phenomenon has been validated by different studies, and this is the current non-risk factors of clinical relapse, including older age, pre-therapy liver cirrhosis, HBV genotype C, and prior treatment history, higher pre-therapy HBV viral load, and surface antigen. And on-treatment response, including the ALT normalization rate. If the patient could achieve ALT normalization within 3 months, these patients have lower risk for the off-therapy clinical relapse. And also, the NUC influence the clinical relapse rate after stopping. There is a stepwise fashion between the between the surface antigen level at the end of treat with the NUC clinical relapse. The lower the surface antigen level, especially lower than 100 units per milliliter for entecavir, the lower clinical relapse the patient will encounter. One study has proposed that host genetic factors may play some role for the prediction, including CTLA4 for the off-therapy virological relapse and clinical relapse, RS3077 for prediction of off-therapy sustained response. There is no consensus about the optimal consolidation duration across different studies. And the most important concern about stopping NUC is the hepatic decompensation. This is the summary slide composed of all cirrhotic patients. On the left-hand side, the hepatic decompensation rate in the patient who had NUC discontinuation is not higher than that in the right-hand side. The hepatic decompensation rate is especially high in the cirrhotic patients who take long-term therapy with poor adherence. These patients have the poorest outcome. And now we move on to the long-term outcome. The HCC incidence in the inactive cirrhotic patients who stop therapy is comparable to that in the patients who take long-term therapy. And this phenomenon has been validated by the 2 independent cohorts from Taiwan. And let's look back at how's the possible immune mechanism when treated with the NUC and stop the antiviral therapy. From the bony studies, we know that the in vitro T cell will be restored after long-term antiviral therapy to suppress the HBV viral load. And after stop, the reappearance of the HBV antigen will stimulate the NK cell function and the HBV-specific T cell. After the period of the antiviral therapy to suppress the HBV viral load, the T cell function restored with decreased exhaustive phenotype in vitro. And recent study also show when the patient have the PD-1 expression HBV-specific T cells, these reflects the immune restoration, and patient may have better HBV control without hepatitis flare. And this may explain about the phenomenon observed in many studies that HBs antigen decline and HB antigen loss rate are more common in the patient who stop NUC. In a recent famous randomized control trial, the Finite study, composed of 21 patients in each arm. 4 patients in the stop arm have HBs antigen loss. 30% of the patients has S antigen loss by 3 years of follow-up. And this is the phenomenon demonstrated by the propenisco mesh study from Taiwan. The figure A shows the HBs antigen decline greatly in the stop arm compared to the long-term treated arm by 8 years. And the figure B demonstrated that the cumulative incidence of HBs antigen loss increased in the discontinued arm compared to the maintenance group. This phenomenon has also been validated by different studies composed of non-serotic and serotic inactive patients. And from our study composed of the 691 patients, nearly half of the patients are serotic. The off-nuke S antigen seroclearance rate increased greatly in the sustained responder with an annual incidence of 6.3%, and the 6-year cumulative incidence as 36%. In contrast to the patients who had received retreatment promptly when encountering clinical relapse, these patients are less likely to have the S antigen seroclearance. This phenomenon has been validated by Kaohsiung Chang'e Memorial Hospital study that the patient with sustained response has the highest probability for off-therapy S antigen loss. And this is the 3 major outcomes after stopping NUC. Half of the patients may encounter clinical relapse, while 1/5 of the patient can achieve sustained response. However, most important of all, we don't want the patient to encounter any adverse event such as hepatic decompensation or liver-related death after stopping NUC when they have the clinical relapse. Thus, it is an important issue to think about when and whom to retreat. Not to retreat too early to halt the possible immune clearance and not too late to prevent the possible adverse events. This is the case series study provided by the Professor Liao. On the left-hand side, he demonstrated that if the surface antigen level decreased while the patient have the ALT flare, it stands for the effective immune clearance, what also be called as good flare. Patients with good flare may not be retreated promptly and can be wait and see if spontaneous S antigen clearance. On the right-hand side, by sequential assay of the surface antigen, we can see that the patients have increased surface antigen and increased ALT level at the same time. It stands for the ineffective immune clearance, and which is also called the bad flare. Retreatment should be considered promptly in this group of the patients. And these 2 graphs demonstrate the retreatment outcome in patients with bad flare and good flare. On the left-hand side, when the patient had bad flare and received retreatment, a prominent decline in surface antigen was observed to 1 log reduction by 1 year. These patients also have greater possibility for the rapid S antigen decline, which defined as greater than 0.5 log by 6 months or greater than 1 log by 1 year. Nearly 70% of the bad flare patients had a rapid S antigen decline during retreatment, contrary to the only 8% in the patient with good flare and received retreatment. On the right-hand side, 33% of the good flare patients who received retreatment has the S antigen rebound. The level increased even higher to that at the pre-therapy timing. This is a summary of my today's talk, that the cessation of NUCs in the chronic hepatitis B patients is possible and practical. Off-therapy clinical relapse occurred in half of the patients and is not uncommon in inactive patients. The clinical relapse pattern differs between patients who stop entecavir and non-entecavir. Functional cure HBs antigen seroclearance occurs greatly in the patient who stop NUC, especially those with sustained virological response. Sequential monitoring of the surface antigen before and during of therapy flare help the physician to differentiate the flare pattern. If the patients have virus-dominating flare, which also called the bad flare, prompt retreatment is suggested. On the contrary, if the patient have the good flare, the host-dominating flare, retreatment may be held if there is no risk of hepatic decompensation and the patient may have rapid HBs antigen decline. Thank you for your attention.
Thank you, and very nice talk. So, we still have 10 minutes, and let's go to the discussion. So,
okay.
Please.
Yes, I think the first speaker, Professor for Tarik Asselah, there are some questions. The first questions, what about the role of plaques in immunodesregulation state?
Yes, plaques plasma exchange
Yes.
with antibodies is a very old and robust strategy for infectious disease because you take the plasma from a contaminated patients, they had developed antibodies, and you try to treat with this. This strategy has been tested in around 10 patients that has been published with good, interesting data. I think we need more information about this strategy. It's a strategy that can be applied rapidly because we have the patient, so it's not drug discovery. It's an interesting strategy, but we're still waiting for strong data in terms of protection and in terms of safety. So we will need to wait. I think the most interesting is also prophylactic treatments. We need prophylactic before the patient gets in a difficult situation in the disease. Thank you, Professor.
Okay. The second question, HCV drugs, sofosbuvir, daclitaxel, has been discussed to have potential for COVID-19 treatment. How are the mechanism of action? How are the efficacy?
Yes, it's a very important question because many virus has some very similar enzymes. And we know that some virus has a polymerase, which is very important to replicate the genomes. And the structure of the polymerase might be similar. So when you put a drug that will block the enzyme site, it can block the polymerase of different viruses like the Hep C, like the COVID, the SARS. So I think it's very interesting. And we know that sofosbuvir, Epclusa, but polymerase inhibitors in Ebola and other diseases have been tested for different viruses. I think so far it's more remdesivir, who has been also tested for other diseases, for Ebola, who is in the first line with short amelioration in hospitalist duration, but remdesivir also target the polymerase. I think for sofosbuvir, there's early data, but we know it's the same company with sofosbuvir and remdesivir, so I think they select remdesivir because of maybe higher potency.
We can take this time to have a few of questions to Professor Jeng. The first question came from Professor George Lau. So, once the patient after the cessation of the NUCs, the patient will have the viral flare, so would you prefer the interferon or NUCs to retreatment?
This is a very good question. Can I answer now?
Yeah, please.
Okay.
Professor, please.
This is a very good question. When the patient has encountered the off therapy flare, we retreat the patients who have the ineffective immune response. But as for the choosing of NUCs or interferon depends on many factors, including the patient's age, serotic status, platelet count, and other, including any steroid function and the patient's acceptance of the treatment of choice. Actually, I do retreat my patients with interferon and also show good response.
Good. And the next one is when to stop NUCs in and E antigen positive and E negative. Could you please repeat it again? Can you solve the question? Can you see the question? And any difference?
Sorry,
any differences for stopping timing for E antigen positive and E antigen negative?
Yes, there is a major difference between the E positive and E negative patient is due to the E antigen existence in the E positive groups. So across different guidelines, there's a consensus that stopping NUC only considered in the patients with E seroconversion plus consolidation duration longer than 1 year in the E positive groups. But in the E negative patients, we don't have the E antigen positive issue. So in this group of the patients, the APASL guidelines suggest that stop can be considered when undetectable DNA for longer than 1 year. So that's a major difference between the E positive and E negative patients. As for the off-therapy response, such as off-therapy clinical relapse, in a recent study conducted by Professor Jianhong Chen in Kaohsiung Memorial Hospital, he compared the E positive and E negative patients who stopped the NUC. The clinical relapse rate and virological relapse rate are similar when the matching of the other factors such as cirrhosis, gender, and the DNA level. So I think that the E negative patients are not at predominantly high adverse event compared to that in the E positive groups.
Good.
Just before the closing this webinar, I think I would like to special thanks to Professor George Lau, Professor Omata, Professor Sarin, and also our President Tabasek, and especially our Secretary Izumi. She made excellent job, really.
So, and Professor Dokumish, please, and give the closing remark, please.
Okay, I think these APASL webinars are very, very useful. There are a lot of people just saw these webinars, and I think we took very, very positive comments about these webinars. I hope these webinars will continue later. But the first APASL WHO webinar will be held in 28th July. I think also we have to continue follow these webinars soon. Thank you very much.
Thank you, and for our speaker, and thank you, and the panelists, and thank you for and the participants, and the Professor Omata, Professor Rin, Professor George Lau, and everybody. Thank you.
Thank you, Professor Wang. Thank you, Professor Dokumish. Thank you all.
Thank you. Yes. Yes.
And wish all of you.
Thank you very much.